So coming to the second case, again, someone comes at 12 weeks, pregnant lady whose TSH is less than 0.01 and T4 is elevated. She says that she has lost some weight in the last 2 months. She has a lot of nausea and vomiting, but is otherwise asymptomatic. So what do you do? There are two main reasons of hyperthyroidism in pregnancy, the more common being gestational transient thyrotoxicosis. It happens in 1 to 5% of pregnancies. It is a normal phenomenon. It's because of the increased HCG in the late first trimester and the early second trimester. It has no adverse maternal or fetal outcomes. So we definitely don't want to treat them because starting ATDs, starting antithyroid drugs can have a lot of adverse outcomes for the mother or the fetus. So we don't treat this condition. On the other hand, we don't want to miss Graves' disease because untreated Graves' disease again can have a lot of adverse outcomes for both the mother and the baby. So it becomes very important for us to know how to differentiate these two. So clinically, what we can look at is that someone, if they give a history of their symptoms antedating pregnancy, if they say that they've had significant weight loss, palpitations, tremors, heat intolerance, loose motions, that happened even before the pregnancy started, it could be Graves' disease. On the other hand, anyone with gestational transient thyrotoxicosis will not be having symptoms antedating pregnancy. A lot of these transient thyrotoxicosis patients will have nausea, vomiting because of elevated HCG. Then when we examine them, if we find some eye changes or a big goiter, almost we are sure that we are dealing with Graves. Again, if we can't distinguish clinically between these two, sometimes it is difficult. We can order a TSH receptor antibody, which will be positive in Graves, or we can do a free T4 again after 2 weeks, and if there is a decline in the free T4 without any medicine, again that confirms the diagnosis of gestational transient thyrotoxicosis. So very important to distinguish between these two because we definitely don't want to be treating transient thyrotoxicosis and we don't want to miss our Graves. So again, if left untreated, for mother it can cause preeclampsia, stillbirth, heart failure, and for fetus it can cause growth restriction, low birth weight. It can cause both fetal hyper as well as hypothyroidism. So if someone who is a known patient with Graves' disease comes to you during pregnancy, what you can do is that if it is a mild disease, if the thyroid profile is good, if she's euthyroid, with minimal dose, you can continue the drug. Now, whether to shift to PTU now or to shift to PTU when the pregnancy is confirmed depends on your clinical decision. If you feel that she might conceive early, if everything else is good, you might shift to PTU at that visit. But if you feel that it might take some more time for her to conceive, you can continue methimazole for some more time, but tell her to come as soon as the pregnancy is confirmed because we need to be shifting to PTU. If there is a more severe disease, we can offer definitive treatments like radioiodine or surgery as well, but they need to be waiting for 6 months before they plan pregnancy then. So there are 3 major things we look at while managing such patients in pregnancy. There are majorly 2 classes of drugs here. We have carbimazole, methimazole on one side and PTU on the other. Now, normally PTU is a hepatotoxic drug, so that's why we don't give it generally. Pregnancy first trimester is one indication where we give PTU because methimazole or carbimazole can be teratogenic. They are associated with embryopathy, so we don't want the fetus to be exposed to these drugs during the first trimester. So in the first trimester, we shift to PTU, but later on, again in the second trimester, we shift to methimazole or carbimazole. That is one thing. Second thing is, the fetal thyroid is very, very sensitive to these drugs. So we never want the women to have a euthyroid state, as in, we never target a total T4 or a free T4 in the mid-normal range, or we never want the TSH to be normal. Because if we are targeting such levels, that would mean that the fetus might be getting hypothyroid because it is more sensitive than the mother. So we monitor very frequently, definitely we monitor at 2 to 4 weeks a lot of these women, and we target a T4 level at the higher end or slightly above the range of normal, and the TSH we never want to normalize. That is one thing. Second thing is that a lot of these patients might be entering remission. So we need to keep a very close eye on them, and if the levels are normal, we might stop the medicine as well. So we monitor TSH receptor antibodies, that is TRAb levels apart from thyroid function test. At the first visit, if it is very high, usually more than 3 times the upper limit of normal signifies high risk. If it is high, we again check it at 20 weeks and then 28 weeks. So fetus can be affected in 3 ways. The mother's high thyroid levels can go to the fetus and cause problems. The maternal TSH receptor antibodies can reach the fetus and stimulate the fetus's thyroid gland to produce more thyroid hormones. And the maternal antithyroid drugs cross the placenta and cause fetal hypothyroidism. So we need to be looking at both fetal hypo or hyperthyroidism. So fetal sonography every month, commencing from 26 to 28 weeks, to look for tachycardia, bradycardia, high activity, low activity, advanced bone age, goiter, all these things to find out if the fetus is affected. So subclinical hyperthyroidism, that is if we are dealing with a normal free T4, free T3, only decreased TSH, we don't treat. No adverse outcomes. If we are treating, if we have a overt hyperthyroidism, we definitely want to distinguish gestational transient thyrotoxicosis, which does not require treatment at all, Graves' disease, first trimester PTU, after first trimester carbimazole. So coming to diabetes in pregnancy, you might get a patient who was diabetic earlier and now is pregnant, or comes with pregnancy and finds out that she has diabetes now, which can be overt or gestational. The prevalence is very, very high. It's around 1/3 of our patients in the ICMR India B 2023 study, 20 to 28% in urban areas, very high number. Happens mainly because of insulin resistance, because of placental hormones like human placental lactogens after 20 weeks usually. The implications of GDM for mother would include increased incidence of preeclampsia, polyhydramnios, operative delivery. For fetus, macrosomia, respiratory distress syndrome, prematurity, and neonatal complications. For someone who has a pre-existing diabetes, for fetus, congenital malformations, including neural tube defects, cardiac malformations, genitourinary gastrointestinal malformations, and I feel an ignored thing, in mothers also there can be complications if they are already a diabetic. Retinopathy can develop even first time during pregnancy. It can worsen if it is already there. So any pregnant lady who already has a history of diabetes should be screened with a dilated fundus examination at first visit and then every trimester if required. And also, if there is an existing nephropathy, it can worsen as sir discussed. So a baseline creatinine and urine albumin should be done in all such patients. This is something that probably is ignored a lot of times.